provider input and provider involvement and oversight. We want consumer outreach and education services. You know, the exchange is not something complicated or onerous. USA Today described it as Travelocity for healthcare. And it's really that simple, a fast, easy way for consumers to go on the World Wide Web and do comparison shopping for health insurance. We think the state should engage in that and join with Mercy and all the other providers you've heard from in improving the care of citizens to Iowa. Thank you very much for this opportunity.
Thank you, Joe. Ted Boeson from our Iowa Primary Care Association, followed by Hale from New Opportunities. Good morning, Ted.
Good morning. We too thank you for the opportunity to present. I'm Ted Boeson, and I'm CEO of the Iowa Primary Care Association and serve in a leadership capacity of the statewide safety net network, which is really the focus of my remarks today. The Safety Net Network was created by the legislature in 2005, and for us, we extremely appreciate the support. It's been a rich experience being involved in it, and it really does show some support and recognition of safety net providers as an integral part of the healthcare delivery system. Primary care safety net providers like rural health clinics, free clinics, federally qualified health centers, and others are essential to meeting the increased demands for primary care. We know the safety net providers played a significant role in meeting increasing demands for primary care service after health care reform in Massachusetts. And we also know that only 10% of our health status is impacted by the healthcare delivery system, while we spend 90% of all healthcare dollars for the support of that system. There are tremendous opportunities to redistribute these funds to support prevention and wellness, improving patient behaviors, addressing social determinants of health. The ACA affords all healthcare providers with opportunities to meet the goals of the triple aim and specifically supports primary care providers like FQHCs in restructuring our operations. Safety net primary care providers are becoming recognized patient-centered medical homes, participating in Medicaid's 2703 Health Home Pilot, and most importantly, committed to continuing to meet the interests of our mission to provide care to the most vulnerable Iowans with an idea on addressing the social determinants of health. Safety net providers have critical experience in meeting the needs of the most vulnerable Iowans with the highest costs, and we know that coverage does not mean access, and there still will be remaining uninsured Iowans not eligible for various programs, with national estimates totaling near 25 million. Safety net providers in particular will need to be equipped with timely, accurate information to assist the patients in accessing programs and understanding changes to the healthcare delivery system. But we are ready for this important work. The Safety Net Network has been a partner in the Commonwealth Fund-supported project with the University of Iowa's Public Policy Center to assess the impact of healthcare reform on the safety net in Iowa. The project, along with technical assistance, resources provided by the National Academy of State Health Policy's Medicaid Safety Net Learning Collaborative, that's a mouthful, as well as resources from the Iowa's Community Transformation Grant, have exposed us to several state models that demonstrate that a community utility, community care team approach to providing health care can yield significant savings to payers and improve patient care. A community utility, community care team is our services provided to the community that everyone contributes to and benefits from and cannot efficiently or effectively be accomplished by an individual practice or provider. In healthcare, this can range from care management to data analysis, and from pharmacy and behavioral health technical assistance for primary care providers to prevention and wellness services, among others. I've got the hook here. I'm going to go quick. So in the very near future, we will be exploring how the community concept utility fits in Iowa. And we will be looking at how this model can interface with ACOs, support patient-centered medical homes, improve patient outcomes and address the social determinants of health. In closing, the development of community utilities and community care teams in Iowa could help us all to avoid unnecessarily duplicating investments in required infrastructure. Instead, we could work collectively to support shared services that benefit all Iowans, lower the cost of care, and greatly improve the quality of care provided to Iowans. Thank you.
Thank you, Ted, and thanks to the contribution that QHCs have made in trying to get Iowa Care expanded to everybody. Peg Donor is here for New Horizons, and John Hale from Iowa CareGivers is on deck.
Hi, I'm Peg Dohrer. I'm with New Opportunities, and we're a community action agency serving 7 counties in west central Iowa. Sure, okay. And I really didn't even plan to speak today. I must have signed the wrong list, but I'll take this opportunity, and I'll be very brief. But a lot of the reform efforts are wonderful, and we applaud them, and certainly they're long overdue. But I think it's also important to think about how no matter how well designed health reform is, and the medical home concept is just really a great, wonderful thing, that there's still going to be the need for gap filling services. And we're one of the agencies that provides some of those gap filling services, such as WIC, maternal health, child health. And I think it's really important that we too be invited to that table with some of the bigger players, because again, no matter how well designed the medical home concept is, people are not necessarily going to be accessing it at the pivotal times when they should. And we are able to access, when women certainly learn that they are pregnant, and sometimes they feel more comfortable coming in a more informal setting than they do in a larger, more clinical setting. So I just wanted to make sure in the talk about accountable care organizations and everybody getting together that some of the smaller community providers that provide those gap filling services, that we too are invited to the table. Thank you.
Well, Peg, as a former legislative staffer, you don't shy away from telling us what to do. You did it as a staffer, and we appreciate it, and thank you for your comments. Actually, you're one of the first speakers to talk about the gap that will exist when we start to restructure the entire system, so thank you. John Hale, Iowa CareGivers, followed by Susan Cameron.
Good morning, everybody. I'm John Hale, representing the Iowa CareGivers. Our formal comments have been submitted for the record, and I'll just briefly outline them here this morning. I take you back to December 15th, 2006. Hotel Savory, downtown Des Moines. Many in this room were there attending Massachusetts Day in Iowa, sponsored by the Iowa CareGivers. On that day, 5 elected and appointed officials from the state of Massachusetts were in Iowa to talk about their groundbreaking approach to providing affordable and adequate health care coverage to their citizens. That day set the stage for what was to come in Iowa. Serious conversations in healthcare commissions, a multitude of work groups, all of which served to get us to the here and now, a time of immense opportunity to show all Iowans that when it comes to affordable and adequate health care, each of them matters and no one will be left behind. The Iowa CareGivers' top priorities for healthcare reform in Iowa include, number 1, the creation of a consumer-focused healthcare exchange, one that is built and managed around the belief that health insurance is complicated, and for many, it's a foreign language that isn't understood and can't be effectively used. Number 2, a robust consumer outreach and assistance program that can use Iowa's SHIP program as a model, with paid staff and volunteers who will be available by phone and in person in locations throughout the state to provide unbiased help. Number 3, an expanded Medicaid program that provides the uninsured and the 70,000 Iowans currently on Iowa Care access to an adequate array of services that most, if not all, in this room have and simply take for granted. This coverage will get rid of the notion and the use of the term charity care, and will allow all Iowans to have and use a doctor's office rather than an emergency room for their routine and periodic care. Number 4, a strong and effective focus on building and sustaining the workforce needed to provide the services that are being promised. Giving additional people access to an insurance card without having the workforce in place to provide the services the card promises makes no sense. It's akin to providing Iowans with a credit card to buy gas for their car, but having few or no service stations to use the card at. Finally, a thought on the process to be used in the upcoming session to deal with healthcare reform issues. And at the Iowa Caregivers, we believe that the process you use derives the results you get. Our written comments provide a video link with a request. It requests a process that Iowans want and that Iowans deserve. Granted, it's unusual to have a YouTube music video referenced in a public hearing presentation, particularly one from 1970 from a band called Canned Heat. But the message of that song, "To Work Together," is just as simple, just as powerful, and just as pertinent today as it was then. Working together means Democrats and Republicans. It means the legislative and executive branch, and it means everybody working with stakeholders, and stakeholders with maximum involvement, with maximum transparency. Thank you all very much.
Thank you, John. And Representative Hedden said she could sing the entire song.
I knew she could. I knew she could.
All right, Susan Cameron, and then Tom Chapman.
Hello, I'm Susan Cameron. I'm here today representing the Iowa Optometric Association, and honestly, we didn't have much to say, so I'm going to just start by saying thank you for holding this important forum. Thanks for the interest in this. Iowa optometrists do take great pride in serving Medicaid patients and those who may not be on Medicaid but need services but can't pay. They're very service-oriented in that way, and they're basically monitoring what is happening, but they do want to make sure that vision services are covered because they are so important to children's ability to learn and just so many things in our life. So, sorry I didn't have prepared remarks, but hey, it's short. Thanks.
Tom Chapman from the Iowa Catholic Conference, followed by Larry Carl.
Thank you. My name is Tom Chapman with the Iowa Catholic Conference, and I really do appreciate the opportunity to be here to present this information. For nearly 100 years, the Catholic bishops of the United States have been advocates for universal health care. Just last month, Pope Benedict XVI told a conference of healthcare workers that good health is a benefit that needs to be defended and guaranteed for all people, regardless of their ability to pay. And so for the 2013 session, the Iowa Catholic Conference has 3 legislative priorities regarding health care. First, we support state initiatives that would make health care more readily available and affordable to all Iowans, including immigrants and their children. Second, we oppose direct or indirect public funding of abortion. And third, we support the conscience rights of medical professionals and religious institutions. The starting point in our tradition is human life and dignity. So we'll be looking to see if these proposals enhance and protect the dignity of human life from conception until natural death. We have a priority concern for the poor. We believe that our health care system should meet the most pressing health care needs of the poor and underserved. And as you've heard many times today, the expansion of Medicaid is a very welcome step in that direction. Also, as was mentioned today, there's still going to be some gaps in the system. So there's still going to be the issue in front of us of whether our health care system truly provides ready access to health care for every person living in Iowa. We know that people of goodwill can disagree about how to achieve these principles or even if these principles are valid. But the fact that we're here today discussing how to accomplish health care for all is a very important step. So thank you very much.
Larry Carl, followed by Arlinda McKeen.
Good morning. My name's Larry Carl. I'm with the Iowa Dental Association, and we represent about 90% of the practicing dentists in the state of Iowa. There is a loophole in the essential health benefits as it relates to the pediatric services and the oral health benefit that's part of the Affordable Care Act that the state of Iowa needs to address and close. Come to find out, we've learned recently that there is a scenario where a family with children could purchase a medical policy without a dental benefit that meets the requirements of a qualified plan and not be required to also purchase a dental benefit for the children in the home. And we would very much appreciate it if the legislature would close that loophole, because obviously Congress intended that there be a pediatric oral health benefit, and it got fouled up. And it's obvious we don't see the federal government changing that to fix it, so we have to rely on the state legislature to do that. The second thing that we're particularly interested in is in the Medicaid expansion population as it relates, of course, to the oral health benefit. We're very concerned that unless there are significant changes made, that the if and when the Medicaid expansion population is adopted in Iowa, it will in essence be a phantom benefit as it relates to the oral health benefit. We point to the Hawkeye program and the oral health program for uninsured children of working families. The Hawkeye program works beautifully. It's a program that time and time again the Public Health Department has assured us there is absolutely no access or barriers to care. It's properly funded, it's properly administered, and we believe that to assure a appropriate benefit for the Medicaid expansion population, it should follow the same design as the Hawkeye program here in Iowa. I have also submitted printed material on the website, so we look forward to working with all of the leadership, and thank you for the opportunity.
And Larry, thank you and your association for the annual free clinics that you give throughout the state. Arlinda, McKeen, followed by John Rossman. Good morning.
Thanks, everybody. We really appreciate your convening this opportunity to talk about a lot of issues and also have a lot of other people in the room to listen to what everyone else has to say. So thanks. I wasn't planning to talk today either, but I was drafted. SVPG supports the work of the Direct Care Worker Advisory Council. We do facilitation, coordination of the activities, and those activities have been directed for the last several years by the Iowa General Assembly. So this is an opportunity to give a little bit of feedback from one of the members of the council who wasn't able to be here today. He couldn't get time off work to come. So he sent his comments and asked that we deliver them on his behalf. I'm not going to look like him at all, by the way. My name is Matthew Clevenger, and I have worked as a direct care professional, a CNA, for 21 years. During most of those years, when people would ask me what I do for a living, and when I would tell them that I am a CNA, usually their response would be something similar to, "Oh, really?" Some people do not treat direct care professionals like the professionals that we are. I was asked 2 years ago to be a part of the Direct Care Workforce Advisory Council. There are a variety of people from different fields on this council, including direct care workers, business owners, and people from community colleges. The work we are doing on the council is an effort to make our profession recognized as a true profession. Other professions, such as nurses, have to do continuing education in order to keep their licenses, and they have to answer to a board. That is what we would like to see for direct care professionals. Having a board for direct care professionals would make direct care professionals more responsible for training, especially if they would like to expand their training into other fields. It also would help employers with the cost of turnover, because direct care professionals would have a better education or training going into the field. Don't get me wrong, the colleges already do a good job at training, but maybe more real-life understanding of the field would help new direct care professionals so that they know what they will experience in this field. Also, in addition to reducing turnover for employers, standardizing the training would result in more quality care being provided in the field. So from my perspective, If the recommendations of the advisory council were implemented and a board was established,